Waste any more time. It is my great pleasure to introduce our speaker today, Dr. Eric Rush. He has all kinds of accolades, but on a personal note, he's part of our faculty and has worked very hard to help us develop this program. So, Eric, thank you so very much for being with us today.
Always a pleasure, Laura. Hopefully everybody can see my slides okay.
Looks good, thank you.
All right, perfect. So I'm going to talk today about the child with multiple fractures, and this is going to be a presentation in two parts. We're going to talk a little bit about process, but then we're also going to talk a little bit about the differential diagnosis, and we'll have some stops along the way. And then if we have time, I have a case as well. Obviously, I would echo what Laura said, that we always value additional cases here with the Rare Bone Disease Echo and are looking for your cases, whether they're interesting cases that you know the answer to, or whether they're cases that we still haven't solved quite yet. So we're very interested in that. So here are my disclosures. So again, the approach to the patient with multiple fractures, and then differential diagnosis of multiple fractures. And even within this part, we're going to have three different sections. One are going to be skeletal dysplasias, which we think about, but then also I think it's important to think about non-skeletal genetic disorders and acquired metabolic bone disease. I think all of these are important to consider when we're looking at that patient. So let's start with the history. You know, every good case starts with a solid history and physical examination, and this is really no different. When you have the patient that presents with multiple fractures, then I think it's very important to know more about the history, because I think we can all agree that not all scenarios of multiple fractures are created equally. And some of the historical clues that are important are things like mechanism and the circumstances of injury, because sometimes we find patients that present with multiple fractures that are traumatic and that we may have an explanation for. But even within traumatic fractures, we may find that some of the fractures are submaximal trauma, and so we may be asked whether it's enough trauma to make sense for a certain circumstance. But sometimes we're dealing with patients where the fractures are completely atraumatic, and that obviously has some different implications as well. Sometimes we see this in patients with known co-diagnoses. And so Laura's going to be presenting a case where that's at play here, because we know that patients with certain co-diagnoses may be more prone to fractures. Some of this may be innate, considering their co-diagnostic condition, or some of it may be acquired for sequelae of their known co-diagnosis that may be predisposing them to bone fracture or bone fragility. And then the number of fractures and the location of fracture. You know, obviously, when we think about fractures, that has a lot of implications. When we see multiple long bone fractures that don't have an explanation, that definitely gets our attention. When we see vertebral compression fractures that don't have a good explanation, that really gets our attention. And there are some patterns there that I think are important. And then the age of onset is, of course, important as well, because I certainly think about multiple fractures in the infant a bit differently than I do the multiple fractures in later childhood or multiple fractures in the adolescent. And I think about that very differently, even though it's not the topic of this discussion, multiple fractures in the adult patient. And so I'm going to embarrass myself by talking about biomechanics. There are a number of orthopedic surgeons in the room, and they know more about biomechanics of bone than I ever will. But so I think about this really simply. I think about this in terms of the forces that are acting on the bone and what fracture we often see as a part of this. And I see the tension being related to the transverse fracture, whereas I see the torsional energies being more a spiral fracture and more of an axial load as being consistent with that oblique fracture. That's all I'm probably ever going to say about biomechanics, but I think it is important to at least keep those in mind when we're evaluating that patient with multiple fractures. All right, now that I've talked about biomechanics, which I'm not an expert in, I'll talk about family history, which I am a little more comfortable with as a geneticist. And I think family history sometimes gets not as much attention as it should in evaluation of the patient with multiple fractures. because I still find that we see family histories that consist of, are there any diseases which run in the family? Not in this group, but I do see this. And unsurprisingly, we don't get a rich data set when we have that sort of resolution to our family history. And if I could put in a plug for pedigree, I'd like to do that, because I think pedigree is, taking a pedigree on every patient who comes in with multiple fractures is the right thing to do. Does it take some time? Yes. It takes about 10 or 15 minutes to do a good family pedigree, but it gives you lots of information, and there's no added cost and a lot of added value to doing that. It's just time and the piece of paper that you take to do your pedigree. It is reasonable still to keep your pedigree targeted to the way the patient is presenting. You don't have to go to go in a deep dive in all of the later onset medical conditions for adults in the family. You can keep it very targeted on the reason why the patient is coming in. I tend to focus, when I'm thinking about family history and multiple fractures, on things like, what is the growth and development like in other members of the family? Are these people who have generally been of normal stature? Are these people who have a tendency to be either shorter or taller in stature? What is the fracture pattern in their family? A complete absence of fracture in a family is very interesting. It doesn't necessarily remove the possibility for genetic contribution, but it definitely changes the way you're framing this. And if you're able to look at that fracture pattern or lack of fracture pattern, you may be starting to arrive not necessarily at a diagnosis yet, but you may understand what a likely inheritance pattern is. At the very least, to say, am I concerned about a dominant condition? Am I concerned about a recessive condition? And am I concerned about an X-linked condition, which is not super common, but we can certainly see. And are there other findings that could lead us to a skeletal or connective tissue condition? Again, I've talked about things like height in the family, and that's important. But I also would be interested in things like, what is their skin like? Are there any cardiovascular findings? Are these patients that present with significant hypermobility? These can be really important things to understand in the family history. And then when you're evaluating the patient themselves, I really look at growth in proportion as being some of the most important things when we have that patient who presents with multiple fractures. Short stature versus normal or tall stature often gives us information of great importance. What is the growth velocity? I do think growth velocity can often be very important, because you may see poor growth velocity in certain genetic or acquired etiologies. And also, one thing to keep in mind is that you will often find, and I've seen this in a number of cases, in pubertal patients who have had significant recent growths and who had multiple fractures in a row that may be associated with submaximal trauma. An example of this was a patient I saw when I was just out of fellowship, and this was a male patient. He's probably about 15. And he was, athletic kid. You look at him and say, you look entirely healthy, no problems there. But he had multiple fractures that were kind of metaphyseal, perimetaphyseal in nature. And if you look at him, you're like, look like a kid who's prone to fracture. But you kind of look at his growth velocity, and he went from about 5'7" to about 6'2". Sorry for our people outside of the U.S., but we'll just say it's a lot of growth happening in a relatively short amount of time. So this is a young man who probably had some temporary decrease in that metaphyseal or perimetaphyseal bone mineral density, and that explained why he had less resistance to fractures with submaximal trauma. And so what do you do for something like that? Well, eventually you just wait it out. And in this case, we didn't find any alternate diagnoses, and that young man ended up doing just fine. Aside from that, there are some key exam clues that we might be looking for when we're evaluating the patient with multiple fractures. And if I could put a plug in, my first plug of several in this talk, I would put a plug in for the echo session in year 3 featuring Dr. Didier Velasco. I think Dr. Velasco is on the call, and she will be talking about dysmorphology examination in skeletal dysplasias, which I think is a very important topic. And if memory serves, Dr. Velasco will be talking about this in November. I, for one, am very much looking forward to that discussion. But some of these key exam clues may lead to diagnoses that we're very familiar with, such as the blue square in this patient with osteogenesis imperfecta. but it may also lead to exam clues and conditions that we would be less familiar with, or at least attribute less frequently to bone fragility. So in this case, we see the hypermobility in the thumb of a patient who has Ehlers-Danlos classic type. And down below, we see the bifid uvula in a patient who presents with Loeys-Dietz syndrome. Neither of these are skeletal dysplasias, but both are interesting in the context of multiple fractures. So what do we do once we have the history and physical? What are our radiologic evaluations? And there's a lot of different possibilities here. But I focus very simply. I focus on an osseous survey in most patients who present with multiple fractures, particularly pediatric patients. Adult patients, not so useful. But the osseous survey is really very helpful. And although this is kind of the list of things that I like to get in an osseous survey, the items in bold are the things that I think are absolutely necessary. I can do a lot with thoracolumbar spine, pelvis, and lower limbs when we're diagnosing a patient with skeletal dysplasias. Not perfect for sure, but those films by themselves can be incredibly helpful in establishing at least a pattern to start working on a diagnosis. And then for these patients, I tend to do DEXA. I tend to do bone densitometry and I have a pretty low threshold for doing that. In some centers, we're moving to different measures of measuring bone mineral density. If you have a center that has CT-based bone density, then I'd say good for you. I think that's a perfectly reasonable thing to do. I don't have access to that yet, unfortunately, and so I am still using DEXA exclusively when I'm evaluating these patients. So something to keep in mind for the radiologic evaluation of those patients. What about biochemical testing? And it really varies. And I think in all patients, there's kind of a set of labs that I like to get in these patients. I always get the comprehensive metabolic panel, phosphorus, 25-hydroxyvitamin D, parathyroid, urine studies, and the urine studies. Understandably, 24-hour is better in the vast majority of cases. That can be really challenging to obtain in kids. And so sometimes I do spot, I cheat a little bit. Again, probably not ideal, but sometimes I'll do that for the sake of expediency. And CBC. Depending on the presentation, I may expand this out. And so I may be looking for inflammatory markers, SED-rated CRP. I may be looking at a celiac serology. I may be looking at lysosomal enzymes. I may be targeting specific skeletal disorders depending on what I think is going on. And you may want to look at things like endocrinopathies, and thyroid is just one aspect of that. But those are just some of the ways that I might approach these biochemically. Again, patients may present in a way that really tilts you towards one diagnosis or one class of diagnoses, and certainly you should feel free to target that if you think you've got a good idea of what's going on. And then again, I'm a geneticist, and so I'm going to go to genetic testing pretty fast. And sometimes, especially these days, I tend to obtain genetic testing at the same time that I'm obtaining the other tests, knowing that the other biochemical tests will be back some amount of time before the genetic test, although that's not often a great amount of time anymore. So we might see that a lot of our biochemical tests come back within a week or so. Our genetic testing a lot of times is still only 2 or 3 weeks if you have a relatively straightforward panel. And genetic testing can be very potent if you're dealing with patients with skeletal dysplasias, or if you're dealing with other known connective tissue disorders, which may feature bone fragility disorders or genetic metabolic disorders. The genetics are generally well known for these conditions, and so it's important for us to be able to leverage this genetic testing pretty quickly. And one might employ one of a couple different strategies for deciding when genetic testing should be done, but the two most common things I see are extremely targeted testing for patients with multiple fractures, and some of this may be done with looking specifically for OI, and certainly not unreasonable to rule out OI if you have a patient with multiple fractures. But I also think it's equally important to know that all that fractures is not OI. So I find that we're moving away from this to some degree of just doing collagen 1 testing, and we tend to default more towards expanded testing based on the phenotype of the patient. Sometimes this may be still a little targeted with things like bone fragility or low bone mass disorders, and that tends to be about 30 or 40 genes. That's a place to start. You could certainly do that. Or connective tissue disorders, if you think it's maybe more connective tissue and not necessarily a skeletal dysplasia, and those are a finite group of about 40 or 50 genes. Or you may do a more expanded skeletal dysplasia panel, and those can be also as many as over 300 genes, depending. So there's a lot of different ways that one might embark upon genetic testing, and these are just a few of those ways. And based on certain context, I've done any of these things. So I think that's a perfectly reasonable thing to do. So I'm going to move on to the second part of this discussion, and I want to talk about a sort of a differential diagnosis and the way I think about these things. And I'm going to do some quick hits on some of our greatest players here, because again, I think everybody here understands that we need to be concerned about osteogenesis imperfecta when we're evaluating patients for excess number of fractures. That's kind of a known quantity, and so I don't want to belabor that point, because I want to have time to talk about some of the things that we may not be considering as much, because we really still consider OI to be our prototypical bone fragility disorder. And I think we have some of the world's experts in osteogenesis imperfecta here today, and they certainly don't need to hear me talk to them about what OI is, because they've taught us about what OI is. But it is the prototypical, and we are familiar with many of the patterns in fractures in osteogenesis imperfecta. We're familiar with the patterns in more severe OI, and I think a lot of us understand OI as an extremely variable condition with different fracture patterns and different times and onsets of fracture, and based on the severity of the disease. Mild OI often presents very, very differently than patients with severe OI. And mild OI is not infrequently occult for a fairly long period of time. And it is true that when I've had patients with multiple fractures and we've uncovered a monogenic cause for this, it's been mostly OI that we found, not exclusively, but mostly OI. So moving through the OI spectrum, I did want to stop on Cole-Carpenter Syndrome. So again, Cole-Carpenter Syndrome is one that can feature bone fragility, certainly. These patients also have a characteristic appearance of macrocephaly with a very prominent forehead. You can appreciate the downslanting palpebral fissures. Again, some of this is common with OI and other related conditions. These patients have more pronounced hypertelorism. They have more pronounced midfacial protrusion. Oftentimes, the ears are more protuberant than I appreciate with patients with collagen 1 related OI. But like OI, they can have things like pectus excavatum. They also have a tendency to have craniosynostosis. Again, low bone mineral density is often seen. One of the things that is characteristic is these thin appearing diaphysis, and so in this case, the femur that you see in panel B is not bowed, but it certainly has a thin appearing diaphysis and what looks like sequelae of a previous fracture. And these patients may have kind of a thin gracile appearance to their ribs in Cole-Carpenter Syndrome. Contrast this with another condition, Osteoporosis pseudoglioma syndrome, which again has significant context behind it. You would probably not be expecting to find this in an otherwise normal patient who presents with occult fractures, although there is variability in this condition like there are other conditions. I think about this as a multisystemic disorder. Some of these patients have intellectual disability, not all. Decreased bone mineral density and fractures are common. Some of these patients will have microcephaly. Some of them will have microphthalmia, and they will have pseudoglioma as a finding. They will have a tendency for hypermobility, as many of these conditions do. And as you can appreciate, they have significant gracile appearance to the diaphysis, but yet a widened, almost bulbous appearance to the metaphyses that you can see. And I think that's nicely exemplified in panel D, where you can see that gracile diaphysis with that kind of that bulbous metaphysis here. So moving on to the abnormal mineralization group, this is one that we also see commonly, and we've had several speakers Dr. White and most recently Dr. Dehere have talked about hypophosphatasia, which is a bone mineralization disorder that is also extremely variable and can be occult. We can see patients that will present with hypophosphatasia that are not diagnosed for many years. We see a significant delay in diagnosis in many cases. And so, for the patients with less severe forms of HPP, we may or may not see limb bowing. We may or may not see fractures, and the onset of fractures is extremely variable. The left panel is a patient with much more severe HPP, whereas the patient on the right is much more what we would see in the clinic, and maybe not know that we're dealing with a patient with HPP. But these patients can have a decreased bone mineral density, although that's extremely variable in patients with HPP. The bowing is also variable, may or may not be present, and they will present with varying degrees of rickets, or in some cases, no rickets at all. These even patients without obvious rickets may still have osteomalacia, and that may be something that is found in adults as well. Other genetic forms of rickets will have varying degrees of excess fracture, and some of these can include what we'll term together as the renal phosphate wasting rickets, and this can include X-linked hypophosphatemia, and can also include both autosomal recessive and autosomal dominant forms of familial hypophosphatemia as well. And there are vitamin D dependent rickets, which are defects in the metabolic pathway for vitamin D, from 1-alpha hydroxylase, 25 hydroxylase, the vitamin D receptor, or VDR2B, which is a defect in the nuclear ribonucleoprotein C. So all of these can cause different patterns of fractures, and the fracturing in these can vary based on the severity of the overall condition, and also varies a bit on age. Some of these conditions, like HPP and XLH, do see a tendency towards more fractures a little later on in life, but they certainly can fracture as children as well. We've talked extensively about skeletal disorders which feature decreased bone mineral density, but I want to spend a little bit of time talking about disorders of increased bone mineral density, because they too can show an excess of fractures. But this should not be subtle when we're dealing with many of the osteopetrosis conditions. So again, increased bone mineral density, which are either caused by poor functioning of osteoclasts or insufficient number of osteoclasts, and which we'll refer to as osteoclast rich or osteoclast poor osteopetrosis. Depending on the severity of disease, patients might have neuroforaminal stenosis, which can contribute to vision and hearing loss and facial palsy. Presumably, we would not be dealing in a patient who is presenting solely with excess fractures. Presumably, we would not be dealing with quite this severity. We would also presumably not be dealing with the severity that can result in encroachment of the bone marrow cavity, and patients presenting with cytopenias. So there, again, a variability in presentation of osteopetrosis, and we can see patients present with a primarily skeletal phenotype. But these patients will have significant increase in bone density. They'll tend to have poor corticomedullary differentiation, again, variable. We can see vertebral bodies with increased density at the vertebral end plates, which can give what has classically been called a rugger jersey pattern. If you're not familiar with a rugger jersey, like I'm not that familiar with a rugger jersey, it just looks like stripes to me, which I guess was kind of the point. But you can appreciate that there are differences in the density in the middle of the vertebral bodies as compared to the end plates, and in many cases it can be quite striking for patients with osteopetrosis. The fractures can be equally striking because the bones are excessively dense, and because the bones lack a certain amount of strength in certain dimensions. We can see sort of a chalk stick fracture that you see in panel 1B, which, as you can see in panel 1D, required pretty extensive repair to be able to hold the fracture together, and it's clearly still not healed quite yet. But these fractures in osteopetrosis can be really striking. Another skeletal disorder with increased bone density is Pycnodysostosis. So these patients are going to have a particular appearance. They can be, in some cases, significantly dysmorphic. There's a tendency for short stature. Some of that short stature can be mild. They can have some other findings, such as open anterior fontanelle, prominent nasal bridge with kind of a beaked appearance to the nose. This patient's nose is not entirely visible, but what you can see, I think you can appreciate, the nose is at least has a high nasal bridge and is somewhat pointed. And I think we can also all appreciate the significant retrognathia that's present in this patient. The patient's hands are not visualized, but brachydactyly is something that is commonly seen in patients with pycnodysostosis, and in particular, the terminal phalanges can be involved. And radiographically, this you may appreciate acrosteolysis in these patients. But if you're looking at other findings, you may appreciate generalized sclerosis. You may appreciate the tapering of the phalanges that is indicative of the osteolysis. And you may also appreciate the hypoplastic mandible and maxilla. These patients can be also prone to fractures. And so the most famous person that we believe at least had pycnodysostosis was the French artist Henri de Toulouse-Lautrec. And he had femur fractures that were present from adolescence. They never did really heal up correctly. And so in every picture you see of him, you see him walking with a cane, and one would wonder if that may be related. But these patients can certainly be prone to additional fractures. And then one thing that bears additional mentioning is neonatal osteosclerotic dysplasias. And so this is Caffey disease or infantile cortical hyperostosis. And this will present oftentimes in a very, very particular way with fever, soft tissue swelling, and pain that will be limited to particular areas of the body, and typically does self-resolve. And recurrence has sometimes been reported, and there has also been reported findings like joint hypermobility and skin fragility that can be seen in adults with a prior history of Caffey disease. So you can see here, significant, and these are obviously pretty dramatic, but significant subperiosteal cortical hyperostosis. And in this case, it's involving predominantly the diaphysis with relative sparing of the epiphysis. In this case, you're seeing this on a long bone or on a couple of long bones, but it can also be seen in bones like the mandible, the scapula, and it's typically caused by one particular variant in Col1A1. So that is an overview, not comprehensive. Can't really do a truly comprehensive overview of skeletal dysplasias that can be predisposed to fractures in the allotted time, but at least gives you an idea of the types of skeletal disorders that we may be curious about. What about those genetic conditions that are not skeletal dysplasias, but are still genetic? And there's a number of those. I want to take a brief stop at inborn errors of metabolism. And I want to put in a further plug. Our colleague, Dr. Patricia Dixon from WashU, will be discussing bone involvement in lysosomal storage diseases in September, which will go a lot deeper than this into all different bone manifestations that can be present in lysosomal storage diseases. And I think that will be a really interesting discussion. But just in terms of a quick hit here, things like Gaucher disease, we can see skeletal involvement, we can see fractures. I tend to see this later. The bone involvement of Gaucher later in the lifespan, but you certainly can see a bone phenotype in patients with Gaucher disease. Menkes disease, again, these patients are strikingly dysmorphic. These patients have a significant involvement, multisystemic involvement in other ways, but they can also have bone fragility. And so when you're evaluating that patient for multiple fractures, you have to be very cued in to the patient's facial features to see whether they are dysmorphic or not. Other specific storage diseases like mucolipidoses or mucopolysaccharidoses, these patients are coarse. They're often short, although not short to a person, and will present with things like dysostosis multiplex. They can fracture. It's not necessarily as common as some of these other conditions, but they can. And then conditions like lysine protein intolerance. These patients can have metabolic crises that occur after weaning. They can have poor growth, nutritional compromise, and they can eventually develop a tendency for fractures. The majority of these genetic conditions are going to be more in the connective tissue space. So we're going to talk about a handful of these. And so I want to start out with Ehlers-Danlos syndrome classic type, because I think this is one that doesn't always come up when we're thinking about patients with bone fragility, and it really ought to. This is the first type of EDS that was recognized by the discoverers, and has recently undergone a kind of an overhaul of the way it's diagnosed. You know, our previous guidelines for diagnosis of all of the Ehlers-Danlos syndromes were a bit fraught, and the 2017 guidelines do improve that to some degree. And so in this case, we do see that these are patients that have more objective findings of hyperextensibility and atrophic scarring, joint hypermobility, other criteria. Most of these are Col5 opathies. There are a small number that are also Col1 opathies, and these can have low bone mineral density and can be prone to fractures. Not everybody is. And I think that if you look at these as a population, it's not as clear. But I've certainly seen several patients, including one particular patient recently, who had who presented with, among other things, fractures. And we ultimately were able to diagnose them with Ehlers-Danlos syndrome classic type in this case. And so these are just some things that we might see patients with EDS. Again, just to disambiguate EDS, Ehlers-Danlos syndrome as a group of disorders is challenging, because if we had been originally describing these conditions recently, we probably would not have organized them the same way. So we are a bit burdened historically by the Ehlers-Danlos, and so I think that, but I think classic type presents with some exam findings that are often extremely helpful. These are patients with a much more dramatic involvement of the skin, and they will have skin fragility that can, in many cases, can be pretty extreme, although not as extreme in some cases as the next type of Ehlers-Danlos that I'll show you. And it will have a tendency to scar atrophically. They also do have generalized joint hypermobility. And some of the minor criteria include things like easy bruising, a particular texture to the skin, molluscoid pseudotumors, things like that. So when I'm evaluating people and I'm concerned for Ehlers-Danlos classic type, I look at their shins and their foreheads first, because I find that that's often where the most obvious excessive scars are in these patients. And these two patients' knees and shins are, in my opinion, pretty typical for what we see with a lot of patients with EDS classic type. Multiple scars. You can see that kind of that hemosiderin staining of the on the anterior surface of the shins, where they've had old areas of hematoma where it hasn't actually split. So that's something to keep in mind when you're evaluating that patient. Patients with dermatosparaxis type, their skin is a lot more lax and fragile. They do have a much more severe bruising. They're dysmorphic in a way that the patients with classic type are generally not. But it's something to definitely keep in mind when you're evaluating the patient overall. So you can see these patients kind of have this almost sagging appearance with relatively prominent orbits because of excessive periorbital skin. They also have the tendency to have short limbs in addition to the fractures. And like most patients with one of the Ehlers-Danlos syndromes, there is a tendency for hypermobility in this case. Moving away a little bit from the Ehlers-Danlos syndromes, it is important to talk about things like Marfan syndrome, which you may not necessarily automatically go to when you're thinking about the patient who presents with bone fragility, because this is the prototypical autosomal dominant aortopathy. So our current guidelines really focus on the effects on the vasculature, which is appropriate, and then the finding of ectopia lentis. But some of the systemic features I think are really important to appreciate when you're evaluating that patient. And these can include things like dolichostenomelia, kind of that long and slender disproportionate appearance. These patients can have pectus excavatum or carinatum. They have arachnodactyly, which can be measured by having a thumb and wrist sign that's positive. They can have hindfoot deformity, which you can see in the top left panel. Some of these patients will also have spontaneous pneumothorax. These patients can also have low bone mineral density, and some of them are prone to fractures. Again, not everybody, but they can be prone to fractures. One condition, and I showed you a picture of a patient with this condition earlier on, one condition that also features, in some cases, pretty strikingly low bone density, I've noticed, is the Loeys-Dietz Syndrome. So again, another autosomal dominant aortopathy, which can present with clinical features directly related to the vascular phenomenon like aneurysm and arterial tortuosity. These patients can also have other exam findings and can be dysmorphic. They can have widely spaced eyes. They can have craniosynostosis. They can also have the bifid uvula that I showed you early in the presentation. And these are caused by a number of different genes, and again, can have low bone mineral density, and they can be prone to fractures. So I'll finish up this the didactic part of this echo with just a few comments on acquired metabolic bone disease. Again, I'm a geneticist, and so I focus on things that are genetic. But when we're evaluating the patient who we presume has a genetic reason for their bone fragility, we can't ignore the fact that acquired causes of bone fragility are absolutely something that cannot be ignored. Some of these can be nutritional. Some of these are secondary nutritional, but vitamin D deficiency. We still see vitamin D deficiency. I've seen several cases of vitamin D deficiency rickets in my career, both when I was practicing in Omaha and now practicing in Kansas City. We see these particularly during the winter. Patients with things like biliary disease and celiac disease and cystic fibrosis, the complications of those diseases can certainly lead to multiple nutritional deficiencies, which can predispose to patients having a propensity to bone fragility. And then also kind of restriction in overall calorie intake and nutrition, as what is seen in things like anorexia nervosa, and also overtraining phenomenon in athletes. Endocrinopathies can also be associated with this. Diabetes can have a negative effect on bone. Patients with hyperthyroidism, that can have a negative effect on bone. Patients with glucocorticoid excess can have a negative effect on bone. And in patients with hypogonadism, particularly, maybe less common in the prepubertal child, but certainly common in adults as a cause of bone fragility. And then iatrogenic causes are absolutely seen. Things like corticosteroids, anticonvulsants, particularly barbiturates and phenytoin, proton pump inhibitors, which has only really been appreciated fairly recently as a potential cause of bone fragility. And then things like loop diuretics that we see, and this is something that we see sometimes in our kids with congenital heart disease who are managed on loop diuretics can have complications because of this. And then even drugs like SSRIs that we use very commonly and increasingly being used in a younger and younger population can have some consequences in bones. And last but not on this list are also chemotherapeutic agents. And so we worry about our patients who present with a history of malignancy as to whether there is a possibility that the chemotherapy might be contributing to this. And then neoplastic disease itself can be related in some cases to bone fragility. And then phenomenon like chronic kidney disease. Patients with reduced mobility can have decreased bone mineral density. We see this in patients with things like CP. We see this with patients with things like Duchenne muscular dystrophy, that we can see significant decreases in bone mineral density. Inflammatory or autoimmune diseases can compromise the bone health. Hemoglobinopathies can compromise the blood health. So there's a lot of things that can be seen that are acquired causes of bone fragility that can predispose to fracture. So with that, I will pause for a minute, and I will open this back up to Dr. Toast.